Good morning, and welcome back. Today's topic is one I want you to take seriously, but I also want to start with something important, so please hear this clearly before we go any further. Nothing in this video is telling you to stop taking any medication you've been prescribed. If you're on any of the medications we're about to discuss, do not stop taking them, do not change your dose, based on anything you hear today. What I want to give you instead is information, so that you can have an informed, specific conversation with your doctor or your pharmacist. That conversation is the goal here, not self-directed changes to your prescriptions. With that said, let's talk about something that doesn't get discussed nearly enough. There's a category of medications, many of them extremely common, many of them available without a prescription, sitting in cabinets across the country, that carry a documented association with cognitive side effects in older adults. Some of these are medications you take occasionally. Some of these are medications people take every single night without a second thought. And the concerning part is that the connection between these medications and brain health often isn't explained clearly, either by the packaging or, frankly, in a rushed 15-minute doctor's appointment. So today we're going to walk through 5 categories of medications that have real, documented associations with cognitive effects in older adults, based on established geriatric prescribing guidelines that doctors and pharmacists actually use. I'll explain what the concern is, why it happens, and most importantly, what questions to bring to your doctor or pharmacist, rather than what decisions to make on your own. Let's start with number 5. Number 5. First-generation antihistamines, the ones found in many allergy medications and over-the-counter sleep aids. This is one of the most common medications in this entire list, and one of the least suspected, because it's sold without a prescription and marketed as gentle and safe. I'm talking specifically about diphenhydramine, the active ingredient in many well-known allergy medications, and also the active ingredient in a large number of over-the-counter nighttime sleep aids, including many products marketed simply as PM versions of common pain relievers. Here's the mechanism behind the concern. Diphenhydramine belongs to a class of medications called anticholinergics, meaning it blocks a neurotransmitter in your body and brain called acetylcholine. Acetylcholine plays a central role in memory, learning, and attention. Blocking it is actually part of how these medications work, which is why they make you drowsy and help dry up allergy symptoms. But that same blocking effect on acetylcholine is the reason geriatric medicine specialists have raised concerns about repeated, regular use of these medications in older adults specifically. Because of this, diphenhydramine appears on what's called the Beers criteria, a widely used, physician-developed list of medications that geriatric specialists recommend using with caution, or avoiding altogether, in older adults, largely because of this anticholinergic effect and its association with confusion, dizziness, and cognitive side effects in this age group. This isn't a fringe opinion. It's part of mainstream geriatric prescribing guidance used by doctors and pharmacists across the country. The tricky part is that a lot of people take this medication regularly without realizing it, because it shows up under different brand names and in combination products. Some nighttime cold and flu medications contain it. Many PM pain relievers contain it. And because it's sold over the counter, people often assume that anything available without a prescription must be inherently gentle and low risk, especially compared to something a doctor prescribes. If you find yourself reaching for one of these products regularly, several nights a week, for allergies or for sleep, that's specifically the pattern worth discussing with your pharmacist. There are alternative approaches for both allergies and sleep that don't carry the same anticholinergic burden, and your pharmacist can walk you through what those alternatives look like for your specific situation. Again, I want to repeat, this isn't about panicking over an occasional dose during allergy season. It's about regular, repeated use over time, and it's worth a genuine conversation rather than an assumption that over-the-counter automatically means no downside. Number 4. Benzodiazepines, commonly prescribed for anxiety and sleep. This category includes medications you may know by brand name, prescribed for anxiety, panic symptoms, or difficulty sleeping. These medications work by enhancing the effect of a calming neurotransmitter in the brain called GABA, which is why they're effective at reducing anxiety and helping people fall asleep. The concern with this category in older adults is well established in geriatric medicine and, Like the previous category, these medications also appear on the Beers criteria list, specifically recommended for cautious use or avoidance in older adults when possible. There are a few overlapping reasons for this. First, as we age, our bodies process and clear medications more slowly, which means these drugs can build up in the system more than they would in a younger adult taking the same dose. Second, there's a well-documented association between benzodiazepine use and increased fall risk in older adults, which itself carries serious consequences, including hip fractures and head injuries. Third, there's ongoing research interest in the relationship between long-term benzodiazepine use and cognitive changes, including effects on memory and processing speed, particularly with extended, regular use. I want to be extremely clear about something important here, because this is a medication category where stopping abruptly can be genuinely dangerous. If you are currently taking a benzodiazepine, do not stop taking it suddenly, and do not reduce your dose without medical supervision. Abruptly stopping these medications, especially after regular long-term use, can cause serious withdrawal effects, including, in some cases, seizures. Any change to how you take this medication needs to happen under a doctor's guidance, typically through a slow, carefully managed taper, not a decision made on your own after watching a video. What I would encourage instead is bringing this topic to your next appointment. Ask your doctor whether this medication is still the right long-term fit for your situation, whether a lower dose might be appropriate, or whether there are non-medication approaches, like cognitive behavioral strategies for anxiety or sleep, that might be worth exploring alongside or instead of the medication over time. That's a legitimate, safe way to engage with this issue, guided by the person who actually knows your full medical history. Number 3, certain prescription sleep medications, sometimes called Z-drugs. This category includes a specific group of prescription sleep medications that were originally developed, in part, as an alternative to benzodiazepines, with the goal of being more targeted and having a somewhat different side effect profile. You may know these by common brand names prescribed specifically for insomnia. While these medications work somewhat differently than benzodiazepines at a chemical level, they still act on some of the same receptor systems in the brain, and they carry some overlapping concerns in older adults. These medications are also included in geriatric prescribing guidance recommending caution in older adults, related to concerns about next-day grogginess, confusion, dizziness, and an increased risk of falls, particularly if a person gets up during the night while the medication is still active in their system. There's also a well-documented, somewhat unusual side effect associated with this category, involving complex sleep-related behaviors, things like sleepwalking, or even preparing food or eating while not fully conscious, with no memory of the event afterward. This is relatively uncommon, but it's serious enough that regulatory agencies have issued specific warnings about it, and it's worth being aware of if you or someone you care for is taking one of these medications. As with the previous category, I'm not telling you to stop taking a prescribed sleep medication based on this video. What I am encouraging is an honest conversation with your doctor about how long you've been taking it, whether it's still working as effectively as it once did, and whether it's time to explore other options for improving sleep, things like consistent sleep and wake times, limiting screen exposure before bed, and addressing any underlying issues that might be disrupting your sleep in the first place. Sleep medications can be genuinely helpful for a period of time, but they're generally intended for shorter-term use, and a periodic check-in with your doctor about whether it's still the right tool is a reasonable and healthy thing to bring up. Number 2, certain medications used for overactive bladder. This one surprises a lot of people, because it doesn't sound like it should have anything to do with the brain at all. But several of the most commonly prescribed medications for overactive bladder and urinary urgency work through the same anticholinergic mechanism we talked about with diphenhydramine earlier, blocking acetylcholine, the neurotransmitter involved in memory and learning, in order to calm involuntary bladder muscle contractions. Because these medications work through this anticholinergic pathway, and because they're often taken daily, on an ongoing, long-term basis, this specific category has drawn particular attention in geriatric medicine. Some of these medications appear on the Beers criteria with cautions related to their anticholinergic burden, and there's been genuine research interest in the cumulative cognitive effects of long-term anticholinergic medication use in older adults, especially when someone is taking more than one anticholinergic medication at the same time, something that happens more often than people realize when different medications are prescribed by different specialists who may not be fully aware of each other's prescriptions. This is actually one of the more important points in today's entire video, so I want to slow down on it. Anticholinergic burden isn't just about any single medication. It's about the cumulative effect of all the anticholinergic medications a person might be taking together. Someone might be taking an occasional allergy medication, a prescribed bladder medication, and perhaps another medication for a completely different condition that also happens to have anticholinergic properties, without anyone connecting the dots that all three of these medications are working through a similar mechanism and potentially adding up. This is exactly the kind of situation where a pharmacist can be an incredibly valuable resource, arguably more valuable than most people realize. Pharmacists have access to your full medication list and are specifically trained to identify these kinds of overlapping effects. If you're taking a bladder medication along with anything else on today's list, or several other medications in general, it's genuinely worth asking your pharmacist directly, "Can you review my full medication list and let me know if any of these overlap in terms of anticholinergic effects?" That's a specific, actionable question that can lead to a genuinely useful conversation, and possibly to safer alternatives if they're appropriate for your situation. And now, number 1, the category that surprises people the most, because it's one of the most widely used medications in the world, and one that most people never think to question. Number 1 is opioid pain medications, when used regularly over an extended period. I want to be very careful and precise here, because pain management is a real and legitimate medical need, and for many people dealing with chronic pain, these medications, used appropriately and under medical supervision, provide a genuine and important improvement in quality of life. This isn't a video suggesting that opioid pain medications should never be used. That determination belongs entirely between you and your doctor, based on your specific medical situation. What is worth understanding, though, is the well-documented association between opioid medications and short-term cognitive effects, including confusion, sedation, and impaired attention, particularly during the initial period of starting the medication, following a dose increase, or in older adults generally, due to the same slower drug clearance we discussed earlier with benzodiazepines. There's also ongoing research interest in the relationship between long-term opioid use and cognitive function over time, an area that continues to be studied, and one where individual responses can vary considerably from person to person. There's an additional layer of concern specifically relevant to older adults, which is the combination of opioid medications with other medications on today's list, particularly benzodiazepines or sleep medications. This specific combination carries a well-documented, significantly increased risk, not just for cognitive effects, but for more serious safety concerns, including dangerously slowed breathing. This is a combination that regulatory agencies have issued specific warnings about, and it's an important thing to flag directly to your doctor if you're prescribed more than one medication from today's list at the same time. If you're managing chronic pain with an opioid medication, the goal here isn't to create fear around a treatment that may be genuinely necessary and appropriate for your situation. The goal is to make sure you're having regular, ongoing conversations with your doctor about your current dose, whether it's still the right fit, whether any other medications you're taking might be interacting with it, and whether there are complementary, non-medication approaches to pain management, like physical therapy or targeted exercise, that might allow for a lower overall dose over time. These are entirely reasonable, standard questions to bring to a pain management appointment, and a good doctor will welcome that conversation rather than being defensive about it. Bringing it all together. So let's step back and look at what actually connects all 5 of these categories. First-generation antihistamines and sleep aids, benzodiazepines, certain prescription sleep medications, overactive bladder medications, and long-term opioid use. 5 very different medications, prescribed for 5 very different reasons, but each one carries a documented, recognized association with cognitive effects in older adults specifically, largely because of how our bodies process medications differently as we age, and in several cases, because of a shared anticholinergic mechanism that can add up when multiple medications overlap. I want to end today with the same message I opened with, because it matters enough to repeat. Nothing in this video is medical advice telling you to stop, reduce, or change any medication you're currently taking. Some of these medications, benzodiazepines especially, can be genuinely dangerous to stop abruptly without medical supervision. What today's video is meant to give you is awareness, specific enough that you can walk into your next doctor's appointment or your next conversation with your pharmacist and ask informed, targeted questions, rather than sitting quietly and assuming that everything currently in your medicine cabinet has already been fully considered in the context of your brain health specifically. Here's a simple, concrete step you can take this week, regardless of what's currently in your medicine cabinet. Make a complete list, every prescription medication, every over-the-counter medication, every supplement you take regularly, and bring that full list to your pharmacist. Ask them directly, can you review this list and let me know if anything here has a known cognitive risk for someone my age, or if any of these interact with each other in a way I should know about. Pharmacists are an underused resource for exactly this kind of question, and many are genuinely glad to sit down and walk through a full medication list with you, often on the spot, without needing a scheduled appointment. If today's video gave you something worth bringing to your next doctor's visit or pharmacy conversation, I'd genuinely appreciate it if you shared it with someone in your life managing multiple medications, particularly if that's an aging parent or a spouse. And if you haven't already, consider subscribing. We publish new, honestly researched videos every week, built to help you stay informed, stay strong, and stay in control of decisions about your own health. Thank you for spending this time with me today. Take care of yourself, ask good questions at your next appointment, and I'll see you in the next one.